All right. Welcome to week 5, and this is where things hopefully start to click. Up until now, you've been doing a lot of seeing. You've looked at cells, you've identified them, you've learned what normal looks like, and you've started to recognize when something feels off. That's a huge step, especially if hematology is new territory for you. But this week, we're shifting gears a bit. We're moving away from just recognizing individual features and stepping into something much more powerful: interpretation. This is where laboratory medicine really lives. In histotechnology, you're used to looking at tissue and asking, what am I seeing, and what does it mean in context? Hematology is no different, except now your tissue is circulating, dynamic, and constantly responding to physiologic changes. What we're going to build this week is a framework, not a list to memorize, not a flowchart to blindly follow, but a way of thinking, a structured approach that helps you take red blood cell indices, morphology, and clinical data and turn them into a story about what's happening in the body. And I want you to keep something in mind from the very beginning. You are not learning how to diagnose diseases this week. You are learning how to think like a laboratory professional. And honestly, that's a much bigger deal. Let's take a second to ground ourselves in what we've already built, because this week doesn't stand on its own. It sits on top of everything you've already done. Back in week 2, we focused on bone marrow and cell development. That was your foundation. You learned where blood cells come from, how they mature, and what normal development looks like. Without that, nothing else makes sense. Then in week 3, we moved into leukocytes. You started connecting morphology to function. Not just this is a neutrophil, but this is what a neutrophil does, and here's how it responds when something's wrong. That was your first step into interpretation. Week 4 shifted gears to red blood cells, and this is where things started to feel deceptively simple. Red blood cells don't have nuclei, they don't have a ton of internal structures, and at first glance, they all kind of look like little pink donuts. But then you started noticing differences: size changes, color changes, shape changes, and inclusions. And suddenly, those simple cells started telling a much more complicated story. You also learned red blood cell indices, so MCV, MCHC, and RDW, which, let's be honest, can feel like alphabet soup at first. But those numbers are incredibly powerful when you know how to use them. So everything you've done so far has been about building pieces: development, function, morphology, and data. This week, we put those pieces together. So now let's talk about where we're heading, because this is the pivot point in the course. This week is not about learning a bunch of brand new content. In fact, most of what you need, you already have. The challenge now is organizing it. You're taking everything from week 4, red blood cell size, color, shape, and indices, and learning how to apply it in a structured way. And that shift is really important. We're moving from recognition into interpretation. Recognition is, that's a microcyte. That looks hypochromic. Interpretation is, what does that pattern suggest about what the body is doing? Those are two very different skill sets. In the lab, nobody hands you a slide and says, just name the cells and call it a day. You're expected to look at the entire picture, the CBC, the smear, the variation in the population, and make sense of it. This week introduces the framework that helps you do exactly that. And I'll give you a little heads up. If you try to memorize your way through this week, it's going to feel overwhelming. If you focus on the process, the steps, it suddenly becomes manageable. So we're not adding more to your plate, we're organizing what's already there. This slide right here is probably the most important one in the entire lecture. Hematology is not about memorizing cells. I know that's what it feels like at first, like you're supposed to remember every shape, every variation, every weird looking red blood cell that exists. But that's not the goal. The real goal is pattern recognition and meaning. When you look at a smear, you're not just identifying individual cells. You're asking, what is consistent here? What is different? What is changing? because those patterns reflect physiology. For example, if you see a population of small, pale cells, that's not random. That is the body responding to something, usually a problem with hemoglobin production. If you see a mix of cell sizes, that tells you the bone marrow is trying to compensate or something is evolving over time. So instead of thinking, I need to memorize every abnormal red blood cell type, start thinking, what patterns am I seeing and what could cause them? That's the shift from student thinking to laboratory thinking. And honestly, once you make that shift, hematology becomes a lot less intimidating and a lot more interesting. All right, this is the slide where I want you to pause for a second and ask yourself, why am I learning this? Because if this just feels like numbers and pink cells, it's going to get old really fast. Red blood cells have one primary job: oxygen delivery. That's it. They are essentially little transport vehicles packed with hemoglobin, moving oxygen from the lungs to tissues. So when something goes wrong with red blood cells, it's not just a lab abnormality. It affects every single organ system. And here's where it gets interesting. Small changes in red blood cells can have huge physiologic consequences. A slight decrease in hemoglobin, that can mean less oxygen to tissues. A subtle change in cell size, that might reflect a production problem in the bone marrow. A variation in the population, that could mean the body is actively trying to compensate. These are not random findings. They are responses. And this is where lab data becomes powerful. A CBC is not just numbers on a screen. A smear is not just something you look at and label. Together, they tell a story. Not a vague story, a very specific one about what the body is doing, what it's struggling with, and how it's trying to fix it. And I love the quote on this slide because it really sums up your role. Your job is to learn how to read it. You're not just identifying cells, you're learning to interpret physiologic language. And once that clicks, hematology stops being overwhelming and starts being kind of addictive. All right, now that we understand why this matters, let's actually define what we're talking about. What is anemia? And I'm intentionally putting this on its own slide because this term gets used a lot in textbooks, in clinic, in lab reports, and it's often misunderstood. Anemia is not a disease. It is not a diagnosis. It is not the final answer. Anemia is a starting point. What we're doing here is stepping into section 2 of your reading. This is where Rodak really starts to lay out the framework. Before you can classify anything, before you can interpret anything, you need to understand what anemia actually represents. Because if you don't define the problem correctly, everything that comes after it gets shaky. And here's where students sometimes get tripped up. They think anemia is about low iron or low blood. Not necessarily. Anemia is about oxygen carrying capacity. That's the key. So moving forward, every time you hear anemia, I want you to mentally translate that into something is affecting the body's ability to deliver oxygen. Now the question becomes, why? And that's exactly what the rest of this lecture is going to help you figure out. Now let's get a little more precise, because in laboratory medicine, vague definitions don't help us much. Anemia is defined by a decrease in one or more of the following: hemoglobin, hematocrit, or red blood cell count. These are your measurable, objective indicators. Hemoglobin is the big one. That's your oxygen carrier. Hematocrit gives you the proportion of blood made up of RBCs. And RBC count tells you how many cells are actually present. When these are decreased, the result is reduced oxygen carrying capacity. That's the common endpoint. Now, here's something I want you to think about, and this is where interpretation starts creeping in. You can have anemia because you don't have enough red blood cells, Your red blood cells don't have enough hemoglobin. Your red blood cells aren't functioning properly, or they're being destroyed too quickly. Same lab result, completely different causes. And this is why just saying the patient is anemic is not helpful on its own. It tells you there is a problem, but not what the problem is. So when you look at this slide, don't just memorize the list. Think about what each component represents physiologically, because that's what you're going to use later when we start classifying. Okay. This slide right here is one of those, if you remember nothing else, remember this moments. Anemia is not a diagnosis. I will say that again because this is where students, clinicians, honestly, even some reports get sloppy. Anemia is a finding. It is a flag. It is a signal. It is your lab saying, hey, something is off. But it does not tell you why. And this matters because if you jump straight from anemia to diagnosis, you're skipping the entire reasoning process. And that's where mistakes happen. Think of it like this. If someone walks into the lab and says, this patient has anemia, that's like saying, this patient has a fever. Okay, but why? Infection? Inflammation? Autoimmune issue? Same idea here. Your job is not to stop at the finding. Your job is to take that finding and work through the framework. What do the indices say? What does the smear say? What pattern is present? What mechanism explains it? That's where the real work is. So anytime you feel yourself jumping to conclusions, pull yourself back and remember, anemia is not the answer. It's the beginning of the question. So now that we've defined anemia from a laboratory standpoint, let's briefly talk about what this looks like on the patient side. And I want to emphasize briefly, because as histotechnologists and laboratory professionals, we are not diagnosing based on symptoms, but understanding them helps you connect what you're seeing in the lab to what the patient is experiencing. The big three you'll see most often are fatigue, shortness of breath, and pallor. And all of these tie back to the same underlying issue, reduced oxygen delivery. Fatigue happens because tissues aren't getting the oxygen they need to produce energy efficiently. So patients feel tired, weak, sometimes even just off. Shortness of breath is the body trying to compensate. If oxygen delivery is low, the body says, okay, let's breathe faster. Let's bring in more oxygen. It's a physiologic response. And pallor, that classic pale appearance, reflects decreased hemoglobin in circulating blood, especially noticeable in the skin and mucous membranes. But here's the key point on this slide. These symptoms are not diagnostic. A lot of conditions can cause fatigue. A lot of things can cause shortness of breath. So while these findings support what we see in the lab, they do not replace laboratory evaluation. In other words, the patient tells you something is wrong. The lab helps you figure out what and why. This is one of my favorite slides because it captures a really important idea in a simple way. Different causes, same result, anemia. And this is where things can get tricky if you're not thinking carefully. You can have anemia due to iron deficiency, vitamin B12 deficiency, chronic disease, blood loss, inherited disorders, or even infections. Completely different mechanisms, but they all lead to the same endpoint, reduced oxygen carrying capacity. So if all you know is this patient is anemic, you are missing the entire story. And this is why pattern recognition matters so much, because each cause leaves clues. Different RBC sizes, different shapes, different levels of variation, different index patterns, and your job is to pick up on those clues and start narrowing things down. I love the phrase on this slide as well. Same symptom, different story. That, my friends, is hematology in a nutshell. Two patients can look identical on paper at first glance, both anemic, but the underlying physiology can be completely different. And if you don't identify the correct story, the patient doesn't get the right treatment. So again, this isn't about memorizing diseases. It's about learning how to distinguish patterns that point you in the right direction. All right, now we're transitioning into section 3, and this is where we bring back something you've already learned, but we're going to use it differently. Red blood cell indices. You saw these in week 4, and at that point they were more about understanding what they are. Now they become tools, and this is a big shift. We are no longer asking, what is MCV? We are asking, what does this MCV tell us? Same with MCHC, same with RDW. This week is about application, and I want to be really clear about something. If you try to memorize index values without understanding how to use them, you're going to struggle. But if you understand what each one represents physiologically, they become incredibly helpful. Think of RBC indices as your starting point. Before you even look at the smear, you already have information about cell size, hemoglobin concentration, and variation within the population. That's huge. As we move forward, I want you thinking, what is this index telling me about what the bone marrow is doing? Because that's ultimately what we're trying to figure out. Okay, let's simplify this. Because honestly, this is where a lot of students start to overcomplicate things. You really only need to anchor 3 key ideas. MCV tells you size, MCHC tells you color, and RDW tells you variation. That's it. If you can remember those 3 relationships, you already have a solid foundation. MCV means mean corpuscular volume. This is your classification tool for size. Microcytic, normocytic, macrocytic. This is often your first branch point when evaluating anemia. MCHC stands for mean corpuscular hemoglobin concentration. This tells you how much hemoglobin is packed into the cell. Normochromic or hypochromic. So when you're layering information, size plus color, and then RDW, which means red cell distribution, width. This one is often underappreciated, but it's incredibly useful. It tells you how much variation exists in the red blood cell population. Are all the cells about the same size, or is there a mix? Because that variation can indicate early disease, mixed populations, or an active bone marrow response. So when you put these together, you're not just looking at numbers, you're building a picture. And here's a little practical tip. Do not try to interpret indices in isolation. Always think, how do these indices align with what I see on the smear? Because when those two agree, that's when your interpretation becomes much more confident. All right. If you remember nothing else about red blood cell indices, remember this. MCV is your starting point every single time. Before you look at anything else, before you even get fancy with interpretation, you ask, what is the MCV? Because MCV tells you size, and size is your first major sorting step. We break it down into 3 categories. Microcytic, which is small cells, normocytic, which is normal sized cells, and macrocytic, which is large cells. And this is not just labeling, this is direction. Microcytic anemia immediately points you towards problems with hemoglobin production. If cells are small, they didn't accumulate enough hemoglobin during development. Macrocytic anemia? Well, now you're thinking about DNA synthesis issues. Cells are growing, but not dividing properly, so they end up larger than expected. Normocytic? Well, that's where things get a little trickier because now the size looks normal, but something is still wrong functionally or quantitatively. So MCV doesn't give you the diagnosis, but it gives you your lane. And here's a practical tip. If you ever feel overwhelmed when looking at anemia, go back to MCV. It simplifies the problem immediately. Think of it like triaging your thought process. Step 1, size. Always. Once you've established size, the next question is how much hemoglobin is actually in these cells? That's where MCHC comes in. MCHC reflects hemoglobin concentration, which we interpret visually as color. So now you're layering information, not just how big the cells are, but how well they're filled. Normochromic cells have a normal amount of hemoglobin. They have that classic central pallor, about 1/3 of the cell. Hypochromic cells? Now you're seeing increased central pallor. They look washed out, pale, like they didn't quite get fully loaded with hemoglobin. And that's not just a visual difference. That's a functional one. Less hemoglobin means less oxygen carrying capacity per cell. So even if the RBC count isn't dramatically low, the quality of those cells is reduced. And this is where things start to connect. Microcytic plus hypochromic, now you're thinking iron-related issues. Normocytic plus normochromic, different category entirely. So MCHC helps refine the story that MCV started. And again, don't memorize combinations. Understand what's happening inside the cell. Because if hemoglobin synthesis is impaired, the cell will show you. Now let's talk about the one that students tend to underestimate, RDW. RDW tells you variation in cell size. Not the average size, that's MCV's job. RDW tells you how consistent or inconsistent the population is. So a normal RDW means the cells are fairly uniform. They all look about the same size. An increased RDW, now you've got a mixed population. Big cells, small cells, everything in between. And we call that anisocytosis. And this is incredibly important because it gives you timing information. A uniform population suggests a stable process, something that's been going on consistently. A mixed population suggests change, something evolving, something shifting, something the bone marrow is responding to. For example, early iron deficiency, you might start to see variation before everything becomes uniformly microcytic. Or after treatment begins, you might see new normal cells entering circulation alongside older abnormal ones. So RDW is like a snapshot of what's happening over time. And this is why I always tell students, RDW is not just a number, it's context. It tells you whether you're looking at a steady state problem or an active process. Let's take that one step further because RDW is one of the most helpful tools you have when you actually start differentiating patterns. RDW can be an early clue. Before MCV shifts dramatically, before morphology becomes obvious, RDW may already be elevated, signaling that something is changing in the red blood cell population. And that's powerful. It also helps you differentiate patterns that might otherwise look similar. For example, two patients might both have a low MCV, both microcytic, but one has a normal RDW and the other has an increased RDW. Those are not the same story. One suggests a uniform population, possibly something more chronic or inherited. The other suggests a mixed population, something evolving, like a developing deficiency. So RDW helps you refine your interpretation beyond just small or large. And when you combine RDW with MCV, you start getting really useful patterns. Low MCV plus high RDW, high MCV plus high RDW, normal MCV plus high RDW, each combination points you in a slightly different direction. And again, you don't need to memorize every possibility right now. What I want you to take away is this. RDW adds depth to your interpretation. It tells you not just what you're seeing, but how that pattern is developing. Okay, this is where we shift gears. Up until now, we've been building knowledge, what anemia is, what the indices mean, how morphology reflects physiology. Now we're going to do something more important. We're going to use it. Because knowing what MCV or RDW means is one thing, but being able to look at a CBC and not panic a little inside, well, that's the goal. This section is your framework, and I want you to think of this like a mental checklist, something you can run through every single time you see anemia. Because here's the reality. In the lab, no one hands you a neatly labeled diagnosis. You get numbers. You get a smear. You get pieces of a story. And your job is to organize that information in a way that actually makes sense. So instead of memorizing dozens of anemia types, we're going to simplify it into a repeatable approach. Same steps every time. And if you stick to the framework, you will not get lost. This right here is your roadmap. If you ever feel overwhelmed, come back to these 5 questions. Step 1. Is the patient anemic? That sounds obvious, but it matters. You always start with objective data, hemoglobin and hematocrit. Step 2. What is the MCV? That's your classification step, your first sorting mechanism. Step 3. What does the smear show? Because numbers are helpful, but morphology gives you confirmation, and sometimes catches things the indices miss. Step 4. What does RDW show? Now you're asking, is this a uniform process or something evolving? And finally, step 5. What is the mechanism? This is where you move from describing the anemia to understanding it. Is this decreased production, increased destruction, or blood loss? And I love this framework because it keeps you from jumping ahead. Students often want to skip straight to diagnosis, but if you follow these steps, the diagnosis becomes much more obvious. Think of it like building a case. You gather evidence first, then you interpret. So let's slow this down and walk it step by step. Step 1 is always confirm that anemia is actually present. And this is purely based on hemoglobin and hematocrit. If those values are low, now you're in anemia territory. If they're not, stop right there. Don't overthink it. And yes, reference ranges differ based on sex, age, and sometimes altitude, but the principle is the same. Low oxygen carrying capacity starts with low hemoglobin. Not low red blood cell count alone. Not it looks a little pale. We're talking measurable, objective data. And this matters because everything else in your framework depends on this step being correct. If the patient isn't anemic, you don't need to do an anemia workup. Now, once anemia is confirmed, then and only then do you move forward. And I always tell students, don't skip step 1 just because it seems simple. Simple steps are where most mistakes happen. Now we move to the most important classification step, MCV. This is where your differential starts to narrow fast. You're taking a huge list of possible causes and immediately organizing it into 3 categories: microcytic, normocytic, and macrocytic. And that's powerful because instead of thinking about every anemia at once, you're now thinking within a specific category. Microcytic, you're focusing on hemoglobin production issues. Macrocytic, you're thinking DNA synthesis problems. Normocytic, now you're considering production versus destruction versus loss. So MCV doesn't give you the answer, but it dramatically reduces the possibilities. And this is why I keep repeating, start with MCV. It's your anchor. It keeps your thinking organized and prevents you from chasing random possibilities that don't fit the data. And once you've identified the category, now you're ready to layer in morphology, RDW, and mechanism. That's how you move from I see anemia to I understand what's happening here. Okay, now we move into what I would argue is the most human part of hematology, because this is where you stop looking at numbers and actually look at cells. Step 3 is morphology, and this is where your microscope becomes your best friend. You're evaluating 4 major things: size, color, shape, and inclusions. Now here's the key. You are not just naming what you see. You are asking, what does this pattern mean physiologically? For example, if you see microcytosis, you already know MCV likely pointed you there. Good. Confirmation. If you see hypochromia, now you're thinking hemoglobin production problem. If you start seeing abnormal shapes, poikilocytosis, now we're getting clues about membrane defects, mechanical damage, or disease processes. And inclusions? Those are like little breadcrumbs left behind by the pathology. Basophilic stippling, the Hal Jolly bodies, those aren't random. They tell you something about red blood cell production or spleen function. So morphology is not decoration, it is data. And here's your pro tip. If the smear and the indices don't agree, trust the smear enough to question the data, because the microscope doesn't lie, but machines sometimes need a second opinion. Now we layer in RDW, and this is where things get interesting, because RDW tells you something that MCV cannot. How consistent is this population? Think of RDW as your variability meter. If RDW is normal, your cells are all about the same size. That suggests a stable, uniform process. If RDW is increased, now you've got a mixed population. Different sizes, different stages, something is changing. And that's the key idea. RDW often reflects a dynamic process. For example, early iron deficiency, you might still have normal sized cells mixed with smaller ones. Boom, elevated RDW. Or recovery from anemia, you may see larger reticulocytes mixing in. Again, increased RDW. So when you look at those histograms and smear images, a tight distribution equals uniform story. A wide distribution equals evolving story. And that matters clinically, because RDW helps you differentiate conditions that might look identical based on MCV alone. So don't ever ignore it. It's subtle, but it's powerful. Okay. Now we get to the part where you stop describing and start understanding. Step 5 is mechanism. And this is where everything comes together. You've confirmed anemia, you've classified it, you've looked at morphology, you've assessed variability. Now you ask, what is actually causing this? And in hematology, most anemia falls into a few big buckets. Production problem, the bone marrow isn't making enough red blood cells. Destruction problem, red blood cells are being destroyed too quickly. Blood loss, well, that's pretty self-explanatory. Or maturation issues, especially DNA synthesis problems like in macrocytic anemia. And this is where your brain starts connecting dots. Microcytic plus hypochromic plus increased RDW, you're thinking production issue, likely iron related. Macrocytic with certain morphologic features, now you're thinking DNA synthesis, B12 or folate. So mechanism is not about memorizing diseases, it's about understanding physiology. Because once you understand the mechanism, the diagnosis becomes a lot less intimidating. Okay, This is your big picture moment. If you remember nothing else from this section, remember this. You are building a pathway, not guessing. Hematology is not about looking at a CBC and throwing out random diagnoses. It's structured, it's logical, it's stepwise. And honestly, that's what makes it manageable. Because without a framework, anemia can feel overwhelming. There are dozens of causes, overlapping features, and similar presentations. With a framework, you start with anemia confirmation, then MCV, then morphology, then RDW, and then mechanism. And suddenly, what felt chaotic becomes organized. And I love this image on this slide because that's exactly what we're doing. You're clearing away the noise, you're making a clean path. So instead of guessing, you're thinking like a laboratory professional. And that right there, that's the goal of this entire unit. Okay. Welcome to the part where everything finally comes together. Up to this point, we've been learning pieces, indices, morphology, RDW, and mechanisms. Now we're putting them together. Because in real lab practice, you never look at just one thing. You are always integrating data. Think of this section as moving from what do I see to what does it mean when I see it all together. And this is what separates memorization from clinical reasoning. Because anyone can memorize that microcytic anemia equals iron deficiency. But a skilled lab professional asks, does the smear support that? Does RDW fit that? Does this pattern make sense physiologically? So this section is about building confidence in your interpretation, not guessing, not memorizing, but connecting. Let's break down why this matters. Your indices, those are your quantitative data, numbers, objective, machine generated. Your smear, that's your qualitative data. That's you, your eyes, your training, your interpretation. And neither one is enough on its own because numbers can miss nuance. And morphologically, without context, that can lead you down the wrong path. But together, now, now you have the full picture. And I love the puzzle image here because that's exactly what this is. Each piece on its own is incomplete, but when you put them together, the story becomes clear. So when you're working up anemia, don't pick sides. Don't be team CBC or team smear. You are both. That's what makes you valuable in the lab. Now let's apply it. Here's a classic pattern. Low MCV plus hypochromia. So immediately your brain should go, okay, small cells, pale cells. That tells you something right away. There is not enough hemoglobin being produced. Now, notice what we did not do. We did not jump straight to a diagnosis. We stayed at the mechanism level. Decreased hemoglobin production. From there, yes, you might start thinking iron deficiency, thalassemia, maybe chronic disease. But the key is you let the data guide you. MCV gave you size. MCHC/morphology gave you color. And together, they pointed you toward a production issue. That's the power of combining indices with morphology. It narrows your thinking without locking you into assumptions. Now let's look at a trickier one. Normal MCV, so at first glance things look fine, but then you look at the smear and it's all over the place. Different shapes, different appearances, nothing is uniform. And this is where students get tripped up. Because if you only looked at MCV, you'd think normocytic, nothing exciting here. But morphology says otherwise. So now you bring in your RDW thinking. Is this a mixed population? Is this an evolving process? Maybe early disease, recovery phase, or multiple processes happening at once? And that's the key takeaway here. When indices look normal, but morphology looks abnormal, pay attention, because that usually means the story is still unfolding. And that's where your role becomes critical. You're the one catching what the numbers alone might miss. Before we move forward, I want to pause here, because this is one of the most important things you will take away from this entire lecture. No single value gives you the answer. Not MCV, not RDW, not the smear alone. And honestly, this is where a lot of mistakes happen in the lab. It's very easy to latch onto one abnormal value and say, got it, I know what this is. But anemia doesn't work that way. It's a pattern. And your job is to recognize that pattern by putting multiple pieces together. So if you ever catch yourself thinking, this one number explains everything, pause. Take a step back. Look at the full picture. Indices plus morphology plus clinical context. Because that's how you move from guessing to actually understanding. Okay, now we're shifting into classification. And this is where MCV really starts to do its job. We classify anemia by size into three main categories: microcytic, which means small cells; normocytic, which again means normal sized cells; and macrocytic, which leans towards large cells. Simple, right? But here's the key. This is just your starting point, not your final answer. MCV helps you narrow the field. It takes a huge list of possible causes and says, focus here. So instead of thinking about every anemia, you're now thinking within a category. And that's what makes your workflow efficient. Because in the lab, we're not just identifying abnormalities. We're organizing them in a way that leads us somewhere meaningful. So think of classification by size as your first big filter. Okay, let's zoom in on the first category, microcytic anemia. So right away, we have low MCV, so small cells. And most of the time, these cells are also hypochromic, meaning they're pale. So what does that tell you? These cells don't have enough hemoglobin, and you can actually see that on the smear. Increased central pallor, thinner looking cells, sometimes that washed out appearance. Now, from a histotechnology standpoint, this is where your observational skills matter, because the analyzer gives you the number, but you confirm the story. And microcytic patterns should immediately make you think something is wrong with hemoglobin production. Not destruction, not loss, production. So again, we're not jumping to diagnosis, we're identifying the mechanism first. So let's take that one step further. If we're seeing microcytic hypochromic cells, what is the underlying issue? Hemoglobin production. That's the key, because hemoglobin is what gives red blood cells both their size and their color. So if hemoglobin production is impaired, cells come out smaller and paler. And now your brain should start building possibilities. Iron availability issues, problems incorporating iron, defects in globulin production. But again, notice the process. We didn't start with diseases. We started with what the cells are telling us. And this is exactly how you should approach every smear. Let the morphology guide you. Let the indices support you. And let the mechanism lead you to the answer. All right, let's talk about normocytic anemia, aka the category that tricks everyone the first time. Because on paper it looks normal. MCV is normal. Cell size is normal. And your brain wants to say, cool, nothing to see here. Except the patient is still anemic. So what's actually going on? You've got normal-sized cells, but not enough of them, or they're not functioning the way they should. And this is where we shift gears a bit in our thinking. Microcytic and macrocytic anemias tend to point you towards production or maturation problems pretty quickly. Normocytic, it's broader. This is where you have to ask, is the body losing cells? Is it destroying cells? Or is it just not making enough? From a lab perspective, this is where your next step matters, and that's usually the reticulocyte count, because retics tell you, is the bone marrow responding appropriately or not even trying? So normocytic anemia isn't simple. It's actually where your clinical reasoning skills start to matter the most. So now let's narrow it down. If the MCV is normal, what does that actually suggest? Three big buckets: acute loss, early disease, or production issues. Let's break that down. First, acute blood loss. If someone just lost blood, the cells they do have are still normal in size. There just aren't enough of them yet. Second, early disease. Think about something like iron deficiency before it becomes microcytic. Early on, the cells haven't changed size yet, so timing matters. And third, production issues. This is where the bone marrow isn't doing its job properly. And again, this is where reticulocytes become your best friend. High retics, the marrow is responding. Think loss or destruction. Low retics, the marrow is quiet. Think production problem. So normocytic anemia is less about what you see and more about how you interpret what's missing. All right, now let's swing to the other end of the spectrum, macrocytic anemia. High MCV, so big cells, and usually when we see big red blood cells, something has gone wrong during cell development, specifically cell division. Because here's the deal. If DNA synthesis is impaired, the cell can't divide properly. So instead of making two normal cells, you end up with one oversized cell. That's your macrocyte. And morphologically, you may also see clues beyond just size. Things like oval macrocytes, hypersegmented neutrophils, maybe even abnormal maturation patterns. So again, don't just look at MCV, look at the smear, because the smear is going to tell you whether this is a clean macrocytic pattern or something more complex like dysplasia. And from a lab standpoint, this is where we start thinking, is this a nutritional issue, a marrow issue, or something systemic? So now, what does macrocytic anemia actually mean mechanistically? Two big ideas here: DNA synthesis problem or maturation issue. Let's connect that. When DNA synthesis is impaired, usually due to things like B12 or folate deficiency, the nucleus can't mature properly, but the cytoplasm keeps developing. So now you've got this mismatch. The cell is growing, but it can't divide on schedule. That's what gives you those large, often oval-shaped red blood cells, and those classic hypersegmented neutrophils. And this is what we call a megaloblastic process. Now, not all macrocytic anemias are megaloblastic. Some are non-megaloblastic, like liver disease or alcohol-related changes, where the mechanism is different. So again, pattern recognition matters, because macrocytic isn't the diagnosis, it's the clue. And your job is to figure out, is this a DNA problem or something affecting the membrane or metabolism? And that is where morphology plus indices really earns its paycheck. All right, welcome to where everything we've been building finally connects. Up to this point, we've been classifying anemia by size, by morphology, by indices, but now we're going to shift from what does it look like to why is it happening? Because in real lab practice, nobody cares if you can just say microcytic. They care if you can say this is microcytic because hemoglobin production is impaired, likely iron related or globulin related. That's the difference between memorization and understanding. So in this section, we're focusing on physiologic mechanisms. What's happening at the level of bone marrow, red blood cell production, red blood cell survival, and overall system balance. Think of this as moving from pattern recognition to pathophysiology. And honestly, this is where you start sounding like a clinician instead of a student. Now let's simplify anemia down to its core mechanisms, because at the end of the day, every anemia fits into one of a few buckets. We've got decreased production, increased destruction, blood loss, and impaired maturation, and sometimes delusional states thrown in for fun. Let's walk through this like a lab professional. Decreased production. The bone marrow is not making enough red blood cells. Increased destruction. Red blood cells are being made, but they're not surviving. Blood loss. Cells are normal. Production may even be normal, but they're leaving the body. Impaired maturation. Cells are being produced, but something goes wrong during development, so they're essentially ineffective. Now here's the key. These mechanisms don't always show up cleanly. A patient might have multiple processes happening at once. So your job isn't just to memorize categories, it's to recognize patterns that point toward a mechanism. Because mechanism equals diagnosis direction. So let's zoom in on decreased production. This is where the bone marrow is either not able or not stimulated to produce enough RBCs. And there are two big categories here: bone marrow issues and nutritional deficiencies. So let's break that down. Bone marrow issues. Think aplastic anemia, marrow infiltration, chronic disease, or even decreased erythropoietin, like in kidney disease. If the marrow isn't getting the signal or it physically can't respond, production drops. Now, nutritional deficiencies: iron, B12, folate. These are the building blocks. No iron, you can't make hemoglobin. No B12 or folate, you can't make DNA. So even if the marrow is trying, it's producing ineffective or insufficient cells. And here's your lab clue. Reticulocytes will be low because the marrow isn't responding appropriately. So when you see anemia plus low retics, your brain should immediately go, this is a production problem. Now let's flip the script. Increased destruction, also known as hemolysis. Here, the bone marrow might actually be doing its job just fine, but the RBCs are being destroyed faster than they can be replaced. And remember, normal red blood cell lifespan is about 120 days. In hemolysis, that span is shortened, sometimes dramatically. Now, destruction can happen in two main ways: inside the bloodstream, which is intravascular, or outside, typically in the spleen, which is extravascular. And the causes? Inherited or acquired. Inherited are things like sickle cell disease, thalassemia, membrane defects, and enzyme deficiencies like G6PD. Acquired, it would be autoimmune hemolysis, mechanical destruction, or infections. Now here's your lab pattern. Reticulocytes will be elevated because the marrow is trying to compensate. So anemia plus high retics, that's your signal. This is a destruction or loss problem. And morphologically, this is where you start seeing those classic abnormal shapes: the schistiocytes, the spherocytes, sickle cells. The smear starts telling the story of how the cells are being destroyed. Let's zoom in on one of the most important mechanisms we've talked about, DNA synthesis problems. Because when DNA synthesis is impaired, everything downstream gets weird. And this is what leads to macrocytosis, those big, oversized red cells. Here's the key concept I want you to lock in. This is not a hemoglobin problem. This is a nuclear maturation problem. So what happens? The cytoplasm, where hemoglobin is made, continues to mature normally. But the nucleus? It lags behind. We call this nuclear cytoplasmic asynchrony. Translation: the cell grows, but doesn't divide on time. So instead of producing multiple smaller, mature cells, you get fewer, larger cells. That's your macrocyte. Now, what causes this? The big players: vitamin B12 deficiency, folate deficiency, and certain medications that interfere with DNA synthesis. And histologically, you'll see macro ovulocytes, hypersegmented neutrophils, and that's your classic megaloblastic picture. So when you see high MCV, your brain should go, is this a DNA synthesis issue? Because that immediately narrows your differential. If you remember nothing else from this entire lecture, remember this slide. Morphology reflects mechanism, not randomly, not coincidentally, predictably. Every shape change you see on a smear is telling you something about what's happening to that cell. Let's walk through a few examples. Target cells, think membrane abnormalities or excess membrane. So liver disease, thalassemia. Spherocytes, loss of membrane, often immune-mediated destruction. Schistiocytes, think mechanical destruction. Something is physically shredding those cells. Macroovulocytes, think DNA synthesis problem. Hypochromia, think hemoglobin production issue. So when you're at the microscope, you're not just identifying shapes, you're asking, what happened to this cell? And that's the shift from student memorizing shapes to lab professional interpreting pathology. Because the smear is not decoration, it's evidence. Okay, this is where it all comes together. We've talked about indices, morphology, classification, mechanisms. Now the goal is integration. Because in the real world, results don't come in neat categories. You get a CBC, a differential, a smear, and you have to make sense of all of it together. So here's your workflow, your mental checklist. Step 1, look at hemoglobin. Is the patient anemic? Step 2, look at MCV. Is it microcytic, normocytic, or macrocytic? Step 3, look at RDW. Are there uniform population or is it mixed? And step 4, look at reticulocytes. Is the marrow responding? Step 5, look at the smear and ask, what story are the cells telling? And then, only then, you start forming conclusions. Not from one value, but from the pattern. Because remember, no single value gives you the answer, but the combination, now that's where diagnosis lives. Okay, let's walk through this like you would in the lab. You've got low hemoglobin, so yes, patient has anemia. You have low MCV, so we're microcytic. We have low MCHC, so we're hypochromic. But we have an high RDW, so we have variation in size. Now pause there. Already your brain should be going microcytic hypochromic anemia with anisocytosis. That screams iron deficiency anemia. Now let's confirm with the rest. Iron, low. Ferritin, low. TIBC is high. Transferrin saturation, low. That's your classic iron profile. And what about reticulocytes? Normal to low, which tells you the marrow isn't responding effectively. This is a production problem. Now let's bring in morphology. You'll see microcytosis, hypochromia, anisocytosis, and poikilocytosis. So the smear matches the indices. And that's the key. Everything aligns. Indices, iron studies, smear, mechanism. That's how you know you're on the right track. Because in lab medicine, when all the pieces agree, that's when you can be confident in your interpretation. Okay, let's walk this out like you're actually sitting at the bench, not just looking at a slide deck. You've got a patient. You've got a CBC. Now what? Step one, always. Is this anemia? Low hemoglobin? Yes. Okay. Now we move. Step two, what's the MCV? In this case, microcytic. So immediately your brain should narrow the field. We're thinking iron deficiency, thalassemia, maybe chronic disease. Step three, look at RDW. Here it's variable, meaning anisocytosis. And that right there is a big clue because high RDW plus microcytosis equals iron deficiency until proven otherwise. Whereas thalassemia, usually more uniform normal RDW. Now, could you stop here? You could make a strong suspicion, but a good laboratory professional doesn't stop early. You confirm with iron studies, smear review, and clinical correlation. So this slide is showing you the process, not just the answer, because the goal isn't memorizing anemia types. It's learning how to think through them step by step. Now let's take that same case and translate it into interpretation. We've already established microcytic, hypochromic, high RDW. So what does that actually mean physiologically? This pattern points to a hemoglobin production problem, not destruction, not loss, not maturation, production. And more specifically, something is interfering with heme synthesis. Most commonly, iron deficiency. Now here's where students sometimes get tripped up. They see low hemoglobin and think, okay, anemia. But they stop there. You need to go one level deeper. Why is hemoglobin low? Is there not enough iron? Is the marrow not using it properly? Is there chronic inflammation blocking utilization? That's the difference between describing results and interpreting results. So when you see this pattern, your mental translation should be, these cells don't have enough hemoglobin, likely due to impaired production. And that, my friends, is clinical reasoning. Okay. Quick reality check moment. You are not diagnosing at this stage. You are simply classifying. And yes, I know, it feels like diagnosing because you're thinking, this looks like iron deficiency. But what you're actually doing is narrowing possibilities. You're saying, this pattern is consistent with a hemoglobin production problem. That's classification. Diagnosis requires clinical history, additional labs, provider correlation, because here's the truth. Different diseases can produce similar lab patterns. Iron deficiency anemia and anemia of chronic disease both can be microcytic. Hemolysis and acute blood loss both can elevate reticulocytes. So your job in the lab is not to jump to conclusions. Your job is to provide accurate, evidence-based interpretation and let that guide further workup. Or as your slide very accurately says, you've got theories, but we stick to what the data supports. Now we get to the part that everyone struggles with at some point, the common pitfalls. Because honestly, most mistakes in hematology aren't from lack of knowledge. They're from misinterpretation. So let's preview what tends to go wrong. Students, and sometimes even experienced techs, will over-rely on a single value, or ignore the smear, or misread RDW, or forget to even check reticulocytes, and they jump straight to a diagnosis. Sound familiar? Here's the big one. Looking at MCV alone and calling it a day. MCV tells you size, not cause. Another big pitfall, ignoring mixed populations. If RDW is high, you might be dealing with two processes happening at once. And if you miss that, then you miss the whole story. And my personal favorite, trusting the analyzer blindly. If the smear doesn't match the indices, believe the smear. Always. So as we move into this final section, we're going to shift from what is it to what could go wrong when interpreting it, because avoiding mistakes is just as important as getting the right answer. So let's talk about the number one mistake I see every single semester. Jumping to a diagnosis way too early. You see low hemoglobin, low MCV, and suddenly it's iron deficiency. And I'm over here like, whoa, slow down, detective. Because here's the issue. Multiple conditions can give you the same pattern. Microcytic anemia could be iron deficiency, could be thalassemia, or could be anemia of chronic disease. So if you jump straight to a diagnosis, you skip the most important step, classification, then interpretation, then confirmation. In the lab, we don't guess. We don't assume. We don't vibe check a CBC. We follow evidence. So instead of saying, this is iron deficiency, train yourself to say, this pattern is consistent with impaired hemoglobin production. Further studies needed. That language matters because it reflects how you're thinking. And in real life, jumping too early can lead to wrong follow-up tests, delayed diagnosis, or completely missing a second process. So rule number one, slow your brain down. You're not here to be fast. You're here to be right. Now let's talk about the most underappreciated lab value on the CBC, and that is the RDW. The one students love to ignore until I put it on an exam. Ha ha ha. RDW tells you how much variation exists in red blood cell size. Not the average, that's MCV, but the variation. And that variation is incredibly useful because it helps you distinguish between conditions that otherwise look identical. Example, microcytic anemia. If RDW is high, think iron deficiency, mixed population of cells. If RDW is normal, think thalassemia, uniform microcytes. Same NCV, completely different mechanism. That's powerful. And it doesn't stop there. High RDW and macrocytosis, think B12 or folate deficiency. High RDW in general means something dynamic is happening. New cells being produced, old cells still hanging around, or multiple processes occurring. So when students ignore the RDW, they're missing half the story. So your new rule, MCV tells you size, RDW tells you consistency, and together they tell you the direction. This one builds right off the last, looking at one value in isolation. And I get it. It's tempting. You see something abnormal and your brain locks onto it. But hematology is not a one-number game. It's a pattern recognition system. CBC values must be interpreted together. Hemoglobin, MCV, MCHC, RDW, reticulocytes, and most importantly, the smear. Because let me tell you something, if the numbers in the smear don't match, the smear wins every time. Analyzers are amazing, but they are not perfect. They can miss mixed populations, fragments, abnormal shapes, cold agglutination artifacts. So if you rely on one value or even just the analyzer, you're setting yourself up to miss something important. And in real lab practice, you always correlate with patient history, clinical symptoms, and previous results because trends matter. So your takeaway here, never interpret a CBC in isolation. You're telling a story, not reading a single word. Okay, so this is your takeaway slide, your tattoo it on your brain moment, if you will. So let's walk through it. Start with MCV. It gives you your entry point. Is it microcytic, normocytic, macrocytic? It doesn't give you the answer, but it tells you where to look. Next, always confirm with morphology. If you're looking at the smear, you are missing critical, if you're not looking at the smear, you are missing critical information. Shape matters. Color matters. Distribution matters. This is where histotechnology and hematology intersect beautifully. Third, think in steps. Don't jump. Move logically. Is there anemia? What's the MCV value? What's the RDW value? Are retics high or low? And then look at the smear. And then we can get interpretation. That structure keeps you from making mistakes. Fourth, and my favorite, patterns are bigger than memorization. If you try to memorize every anemia, you will hate your life. But if you understand patterns, you can work through anything. And that's the goal. Because at the end of the day, you are not just running tests, you are interpreting biology. You are connecting numbers to physiology. And yes, sometimes you will absolutely be saved by the lab. Okay, so we made it. And if your brain feels a little full right now, good. That means I'm doing my job. Because what we covered in this section is not just content, it's a framework. And that's the difference. You are no longer just memorizing types of anemia. You are learning how to approach anemia. And that's a skill that translates directly into real lab practice. Because when a CBC hits your bench, no one is handing you the answer. You're given numbers, a smear, and a patient story that you may or may not fully know. And your job is to start making sense of it. So this wrap-up is not about cramming more information in, it's about stepping back and asking, do I understand how to think through anemia? Because if you can do that, you can handle anything I throw at you on an exam. And more importantly, anything you see in the lab. So let's pull out the key pieces and make sure they stick. If you remember nothing else from this lecture, remember this slide. First, anemia is a finding, not a diagnosis. This is huge. Low hemoglobin doesn't tell you why. It just tells you something is wrong. Your job is to figure out the why. Second, MCV guides classification. This is always your starting point. Microcytic, normocytic, macrocytic. It's your roadmap, not your destination. Third, morphology supports interpretation. Numbers get you close. The smear confirms it. This is where your histotech brain shines. You're trained to recognize patterns visually. Use that. Fourth, RDW adds context. It tells you whether the population is uniform or mixed, and that can completely change your interpretation. So don't ignore it. And finally, think in mechanisms. This is what separates memorization from understanding. Ask yourself, is this a production problem, a destruction problem, a blood loss issue, or a maturation defect? If you can answer that, you're already ahead of most people because now you're thinking like a clinician, not just a student. Last thing, and this is the part I really want to stick with you. The cells are not random. They are responding to something. Every microcyte, every macrocyte, every weird, misshapen cell that makes you go, what on earth is that? It's not random. It's physiology. It's the body trying to adapt, compensate, or survive. And your job is to figure out what story those cells are telling. Not guess, not memorize, not panic, but interpret. You are essentially doing detective work, but with biology instead of fingerprints. So when you look at a smear or a CBC, I want you thinking, what mechanism fits this pattern? What process could explain these findings? What piece of the puzzle am I missing? Because that's how real laboratory professionals think. And that's how you move from I studied anemia to I understand anemia. And trust me, when you get to that point, you really will feel like you've been saved by the lab. Thank you.